I'm Michelle Sherlin, and I am the simulation specialist for the Holyoke Community College in Holyoke, Massachusetts, the Division of Nursing. Our simulation center is a subdivision of our overall nursing learning lab, and it's 4 beds. We have a newborn simulator, a pediatric simulator, and 2 adult simulators. We've been able to integrate our simulation into every semester of our nursing curriculum for both the RN and the LPN program. I actually came from a large medical center that had started with simulation probably about 10 years ago now, and then got involved in some special projects with some local community colleges in simulation and nursing education. And then I took this position as the coordinator of the simulation center at HCC about 2 years ago. So really starting that program from the ground up has been my experience. My presentation is going to be part of the Trends in Simulation, and I'm going to be talking about how we use unfolding case studies to maximize our learning and also allow us to get a large number of students in our nursing labs through a simulation case, an entire case, while only participating physically in a small portion. So we use a combination of live observation via audio-video equipment, so students in the classroom are observing their peers, and the students that are in the room with the patient are performing a small portion or a portion of a shift per se, and we have unfolding events planned as the case goes on, and the students take turns going in and caring for the patient, picking up where their peer left off, having to give an intershift report, having to communicate with a physician. We use phones, and we have people who they SBAR to. We incorporate as many things as we can in as short a period of time as we can, allowing us to do a really extensive pre-brief, debrief, while allowing everybody to be immersed in the scenario together. I think it's valuable for several reasons. One is it maximizes the involvement in the learning. They're not just reading a case, they're actually watching it unfold before their eyes. It also creates an environment in which the students become accustomed to giving peer-to-peer feedback, which we know in patient safety research is huge. People don't speak up, people don't say, I think you need to stop there. That wasn't the way it's supposed to be done. People aren't comfortable with that. They're not comfortable with receiving that. The way this model is set up, the students that are observing are required to use a flip chart and write down their observations, both good and suggestions for improvement for their peers. The students that come out of the room have to talk about what they did well, what they may do better next time, also on a flip chart, immediate feedback. Then they sit down, watch their peers. Now they become the observer. They need to give their peers feedback. They learn how to give positive criticism, how to receive it, what it feels like maybe when it's not so positive, and how they can improve on that. And all the while they're learning and improving their patient care. I think it's really comprehensive. I like the fact too that it's local, that most everyone that I've sat and rubbed shoulders with is nearby. So I feel like it really is a great place to collaborate, to create connections with other organizations that may be more like where I come from, that we might be able to work together in the future. So I like that environment that they've set up.